Good morning, everyone. Thank you for coming out on this wonderful, beautiful, sunny spring Bay Area day. I'm so happy that the weather's turned for Dr. Scott in from New York City. Thank you again. I know everybody's, very busy schedules. Particularly our local county board of supervisors had a very long day yesterday. So I want to thank all the county staff who are here, particularly Daniel Cow from Supervisor Lee's office, any of the other supervisors' offices. If I don't know the staffers, I'm sorry. So again, thank you for taking time out of your day and your week to be here for this very important conversation. I can't tell you how delighted we are to have folks from county departments, public health, behavioral health services, from other agencies, behavioral health agencies, and foundations and folks in the community. Now, all of you know, in some way have been are interested or involved in the thinking about trying to mitigate the opioid epidemic. This is something that is widespread. It's gaining traction locally. And in some ways, it may remind some of us of what it felt like in the early 2000s as meth kind of took over our treatment system locally and took over much of our substance use disorder lives. We are very, very fortunate to have a national leader on the opioid epidemic and what to do about it. And here today in the Bay Area, and I cannot thank Dr. Karen Scott for extending her stay to come and talk to us here in the South Bay. And I just want to hit some of the finer notes around Dr. Scott. So again, Dr. Scott is the president of the Foundation for Opioid Response Efforts. She's here all the way from New York City, as I said, and I'm very fortunate to know Dr. Scott as a former member of her Scientific Advisory Council and more recently as a board member. Founded in 2018, FORE is the only national foundation that has a singular focus on finding and fostering solutions to the opioid crisis. To date, FORE has distributed 102 grants, and Karen will talk about this in a minute. But specifically, Dr. Scott. She is a board-certified physician in preventive medicine with more than 20 years of experience in healthcare policy, quality improvement, health services research, and public health. Dr. Scott has worked with public health and delivery system leaders to redesign care and promote health equity, quality, and patient safety, and population health improvement. Dr. Scott's previous roles include senior leadership positions at the Commonwealth Fund, a national health philanthropy focused on improving health access and quality of care. Dr. Scott has also held leadership positions in large delivery systems at New York Health and Hospitals and New York Presbyterian Hospital. Additionally, Dr. Scott served as the Chief Medical Officer in the Office of Assistant Secretary for Health at the U.S. Department of Health and Human Services, the ASH, for many of us who were in federal service. We overlapped in the Obama administration for a few years. And man, I wish I had worked with Karen back then, because I think it would have made my federal service much better, much better, and made me more effective. That's, I think, for sure would have if I, darn it. But one of the things I think that we will see and in conversation in a bit is how the right person at the right moment, in the right place, can have such a profound impact on such an intractable issue. So again, my gratitude,
David.
my absolute gratitude for Karen for extending your stay here. And so with that, I would like to turn it over to Dr. Karen Scott.
Wow, thank you, David. It's a breathtaking introduction. Thank you so much. I wish I'd also known you when we were both at in Washington in the administration.
Oh no, I don't think you would.
No?
Actually, yeah, I was way down. Yeah.
Those are the days where when you first get to the Humphrey Building, you're like, when am I going to get to the White House? And by the end of it, you're like, I can't believe I have to go to the White House again. So, I hate going to the White House. It was never as fun. It's really a pleasure to be here. David is incredibly kind and generous with his introduction. But for me, this is one of the privileges and joys of my role, and that I get to travel and then I get to learn and have conversations with people who are really on the front lines, doing the work, trying to take care of people who are in treatment and recovery, trying to change policy to make that easier to do, trying to develop programs. So as I was saying earlier, I learn from every conversation that I have. So I really find this one of the most rewarding parts of my job. Plus, after winter in New York, I did drive out this morning and it was really sunny. So while I don't usually drive to work or anywhere, being able to drive in sunshine this morning is certainly an added treat. So thank you. Thank you for that. It's really a pleasure to be here and share this with all of you. I'm going to just talk a little bit more about some of what we've learned so far in the first 5 years or so of funding work to address solutions to the opioid crisis through the foundation's work, and then we'll have more of a conversation. Let's see. Nope, wrong one. Okay, so as David said, the foundation was founded late in 2018 as a private national grant-making foundation. Again, set up to support solutions and accelerate solutions to the opioid crisis. And we set out to do this by understanding, as a fairly small foundation, that we would really be focused on developing and supporting partners, that we would be focused on having the people most affected at the center of everything we do, and that we would be focused on evidence-based solutions. So drawing out what we knew as best we knew it, and helping to spread and disseminate and sustain that work. So with patients at the center of what we do, we've focused on supporting proposals, projects that focus on expanding professional education. And I would say that started out with training primary care providers, and then we layered on more focus on nurses and peers, and then we layered on just recently a project with young attorneys who want to work in legal aid services and work in medical legal partnerships to address some of the more legal issues that families with opioid use disorder, substance use disorder may face. A lot of our work is focused under payer and provider strategies, so those are opportunities to support programs or pilot innovative ways of linking people with treatment services as well as recovery services. Policy initiatives, we do support some work that's more health services research and analysis to inform policy at state and federal level, and public awareness. We do a lot of we want to make sure that what we're learning from all of the work we support is really getting out as broadly as possible and picked up. Again, we are able to support a few projects around the country, but we think the learning from that can really have even a greater impact. So that's us. This is I'm always really proud of our map. And if you go on our website, you can expand it more and see exactly where all the dots are. But we are national. And so we awarded our first grants in March 2020, which you might remember for other reasons, but we remember it mostly for awarding our first set of grants, 19 grants at that time. Since then, we've added to that. So with our recent announcements, we have awarded 104 grants, and that's a commitment of nearly $42 million that the foundation's made to date across those different pillars of work. You can see there are a few spots in the country that we haven't gotten to, but we pretty well have, we're getting a sense of what's happening in different kinds of projects and work from Alaska across to New England and down to Puerto Rico. So my staff keeps saying, when is the Hawaii project coming? So here are the main program areas that we've focused on so far. The first, as I said, our first 19 grants really launched our first program on improving access to treatment for vulnerable populations. When we started, we did a lot of advisory meetings and discussions to identify where we would start. Again, we were coming in with relatively small dollars compared to the federal government, compared to the opioid response dollars, and yet where we kept hearing was, in terms of where there were big gaps, vulnerable populations, and where we knew there was a strong evidence base for things that worked, it was around the treatment piece. It was around expanding access to buprenorphine in particular, and linking more people with care. And this was 2019, 2020, so it was before the waiver for prescribing buprenorphine was eliminated. So a lot of that training and support was to train primary care clinicians to be able to prescribe, to get the waiver and prescribe buprenorphine in different settings, in FQHCs, in health centers, in local health departments, different primary care settings, including in obstetrical and perinatal settings. We rapidly then switched to, this is a little bit before David joined us, I think, had to rapidly in 2020 switch to trying to respond in a way we could to the COVID-19 pandemic. So we heard that there was a real need from smaller recovery organizations to keep people connected. And those were not organizations that had planned for, buying Zoom licenses or laptops or, having internet connections to be able to serve their recoveries. So we did a lot of smaller grants to help that work keep going, as well as some research grants to make sure we were evaluating and learning from some of the temporary changes during COVID. So this was a time when SAMHSA said, in the interest of safety, keeping people safe from COVID. There were more flexibilities around use of telehealth, including for prescribing buprenorphine. There were more flexibilities around methadone treatment, so you could do take-home dose, extend take-home dosing, so someone didn't have to come in every day and potentially be exposed to COVID. And so we wanted to make sure that we were learning from those, that there would be a lot of learning out of that, because we thought it could inform, and indeed we're seeing it is informing ongoing, more permanent policy. And that's probably best reflected in the new SAMHSA rules for opioid treatment programs, which came out about 6 weeks ago. And indeed, some of our grantees were referenced, and were some of the work and findings from that work has helped to shore up the importance of keeping some of those flexibilities. We have a program we call our Innovation Challenge, and we focus there on what are multidisciplinary approaches to addressing what we kind of always comes down to. It always comes down to stigma. As much as you try to work on, there's always that intractable barrier around how do we address the stigma. And the other one for us was also, how do we get more timely and actionable data? We saw on the one hand COVID dashboards, and every day you knew how many people, unfortunately, had been affected by the virus, but the CDC data is 2 years old. We're still working with 2018 data on how many people had died from an overdose. So we've got some really exciting set of projects in both of those areas that have really developed some novel approaches to the data checking and getting that information out to communities, as well as developing some training for different types of providers to address some of the implicit and explicit bias issues. And then we launched a program. We have a big investment in what we call our family and community-based prevention program. And this is a program where as we thought about prevention, we again wanted to focus on the families at highest risk. So families where there's a parent, and for us, we define that as where there's a parent who's in treatment or recovery from a substance use disorder, and where the kids might have been exposed or might have an increased risk of being exposed to an adverse childhood experience. May have seen a parent overdose, for example, and then show up at school the next day. So some of those programs are supporting social workers in the schools in rural West Virginia counties. A large training program through the University of New Mexico's Project ECHO, remote training on adverse childhood experiences, and the link to SUD, that's available actually for anyone to join. But interestingly, a lot of those programs, interestingly and not surprisingly, a lot of those programs are really also bringing health and education much closer together. So that's one of the first Project ECHO trainings, which was developed to do things like train primary care providers to treat hepatitis. It's the first Project ECHO that's really focused on school staff and giving everybody in the school, including clinical staff, nurses, school nurses, an understanding of adverse childhood experiences and how that might increase the risk of substance use disorders. So that's a little bit, and I can't leave the family-based prevention without saying that our newest grant in that area is actually the Sesame Workshop. And so Sesame has a Muppet called Carly. You can go on YouTube and find Carly. She's not on the TV show now, but Sesame Workshop that does their social impact programs is developing a special set curriculum and set of programming around Carly. And Carly's a 6-year-old whose mom is in treatment and recovery for opioid use disorder. And she's had to be in foster care while the mom went, which is very relevant, right? While the mom went to a treatment facility that didn't take children, she had to go to foster care. And now the next layers of the story will be the mom coming out of treatment and a reunification, and how does Carly manage that and deal with that. So that's the content that they're developing now with our grantees. And then it'll be available sort of widely from there. So I have to say, David, it's our only grantee where I've had a conversation about how does Elmo travel through airport security? But it is what we all want to know, right? So you have to have moments. This is hard work. So you have to have some moments of just, how does that actually happen? And then last year, with much pushing from our board, we did something a little bit different. And most of our work's funded through national calls for proposals. But the board asked us, our board asked us, who hadn't gotten through that process? You know, we had a lot of great grantees, but who wasn't making it through? And as I looked at that, I mean, the answer was the smaller community-based organizations who, you know, maybe didn't have as much experience with grant writing or putting together a budget, or our first RFPs were very project-oriented, and they just needed like an accountant, you know. So we did an RFP. And awarded 22 grants last year, which we call our CBO community capacity building grants. So very much tell us what you do, tell us what you need to do more of it in your community and the impact that you're making, and we'll see what we can do. So many of those grants are supporting bringing on a peer to work with families or be able to sustain having a peer on their staff. Some of them they needed an accountant, because if they couldn't get a proper budget, they couldn't apply to SAMHSA. So, these things can build on each other. Databases to be able to track who they're seeing. Again, if you're going to apply for other funding, you need to be able to talk about, what your impact has been. They're doing incredibly well, and I hope that this won't be our only cohort of CBOs. So I'll put that plug in for my board member. And then we really try to make sure that we're drawing out the lessons learned from all of our grantees and making that available more widely. We do webinars at least every quarter, and have some of our grantees focused on those. And then on our website, you would find a range of issue briefs and policy briefs, grantee spotlights, all really delving into more of the specifics of the work. So that's a bit about what we've been trying to do in the last 5 years. Across all of our programs, we, again, have really focused on wanting to work and to support populations at highest risk of overdose mortality and morbidity. And that certainly includes women who are pregnant, parenting, postpartum, women, also includes, and these are intersecting sometimes, unfortunately, but people coming involved in the criminal justice system, certainly includes, as you look at the overdose rates now, particularly African American and indigenous populations as well. So we really think, as we look at proposals, where can we have an impact on these groups that are particularly impact. In terms of perinatal, maternal health, we know that the number of births complicated by OUD nationally has really risen dramatically over the last couple of decades. It's a significant contributor to maternal mortality. So a lot of conversations I have, even if people aren't really focused on substance use or opioid use disorder, there's a much broader conversation, certainly around maternal mortality. And particularly in Black and Indigenous communities. So particularly in Washington, I try to make it, I was like, it's not just about OUD, but this, it's not an OUD issue. This is a maternal mortality and morbidity issue. In some states, such as Illinois, it is the leading cause of maternal mortality. But we also know that pregnant parenting people face unique and significant challenges in accessing care. Often just because they are pregnant, and it's sort of like, oh, we don't want to touch that. That's either too complicated or too stigmatized, or not really sure. I know how to treat someone when they're not pregnant, but do we really put them on medications if they're pregnant, etc. So a lot of information gaps that need to be filled in important ways. And we also know that we have a real opportunity with many states now expanding their Medicaid coverage to 12 months postpartum. Is a particular opportunity to think about what's needed for someone who is postpartum in treatment for opioid use disorder, and and potentially has that coverage for a much longer period of time. The data from that was from about 2018, 2019 was that you see an increase in overdoses postpartum about 6 or 7 months after delivery. We think that coincides with people really falling out of care. If you do any care after the delivery, it's more about the baby than your own care, or you've lost your health insurance. If you lose that whatever connection you had to treatment, the risk is going back to use and having an overdose. So that's what we're trying to avoid in a lot of the work that we're supporting. And then we all know that this is not just about the medical piece or the treatment, but we really need to think about what the comprehensive set of services are to not only to do more than save the life, but also to have to increase well-being and have a healthy family. So in terms of social and psychological issues that need to be addressed as well. And I think we have a set of grantees within our 104 that are really focused on this population and really think about that continuum, which again is how I learned all this. So, Isabel, you can tell me if I'm talking too much. Just briefly, I'll say I did have an opportunity with one of our grantees and my program director to do a commentary in the Journal of Maternal and Child Health and highlight particularly some of the unique issues facing women, women and individuals who are pregnant and parenting. And those are, as I mentioned, can be around not finding a provider who feels comfortable or feels they are trained to treat someone during a perinatal period. There's also a lot of fear around being stigmatized when you go into the healthcare system as someone with both a pregnancy and children and an opioid use disorder, but also fear about involvement of child welfare investigations, and in some states even involvement of criminal justice based on potentially a positive drug test. So again, a lot of the areas that our grantees are trying to address. Let me talk a little bit about them. This first project doing from the Friends Research Institute and UCSF is called Doing Right at Birth. And their whole focus is around the child welfare reporting set of issues and the concerns that for many hospital staff, the the leaning towards over-reporting. So they have done a lot of work with a community advisory board, with hospital staff, both clinical and administrative, to develop a training for hospital staff on giving people a better understanding of what's required in terms of reporting, what's not required, what other considerations, what might be alternatives, and giving, particularly for residents where, interesting, they did some preliminary work that said, particularly as a young, let's say, a pediatric or obstetric resident, you're thinking about, well, surely child welfare sounds like a helpful thing, right? Surely this family needs more help. We can't do that in the hospital. Let's get child welfare to help them, without maybe appreciating the risks of family separation, the risks of never, the family not being able to reunite, and the potential negative impacts of that on the child. So trying to really broaden that and give hospital staff and others a different framework for thinking about it. And that training is now available through their website. We'll be disseminating that. I will say part of the project is we supported them to create a cohort of 20 sort of junior clinicians in hospitals to help be advocates in their local hospitals. And in the Massachusetts General Hospital in Boston, just recently announced a couple weeks ago that they were changing their urine drug screening policy from one where everybody was getting screened, and which generated then a lot more referrals to child welfare, regardless of the reason, to a much more targeted, tailored, clinical reason for doing the screening. So we're having an impact locally in those hospitals. Hopefully that will help to drive more change. Also at UCSF is a program called Team Lily. This is run by an amazing young obstetrician named Dominika Seidman, and the population that they work with are pregnant women who also have a serious mental illness diagnosis and are unstably housed. And they bring them in, they get them through, they engage them in treatment, they have a whole team around them who work on all of the social issues. And often, obviously, the first one is housing, safe, stable housing. They have a residential program that they then can transfer them to after delivery. And they've actually been able to work with the child welfare in San Francisco and get agreement that if the patient is engaged in Team Lily, that child welfare will sort of step back a little bit and and allow mom and baby to go through the program. They stay with the kids for 2 to 3 years, with the families for 2 to 3 years. So it's actually allowing us to see how those kids do as they get into preschool, as well as continuing to support the mom. They've done, even in this environment, the majority of the moms that have gone through their program in the last 2 years are healthy, are alive, and are still engaged in the program. They're local. That's certainly one that people should know about and learn from. So very early on, the first site visit I did was to University of North Carolina Horizons program. We wound up funding them in a project called Jenna's, but as a little bit of detour. I realized one of the other perks of my job was that I would occasionally get to still hold a baby, even though mine are like in their 20s. So that was, he's now 4 years old. So, but Jenna's project, what the UNC did with our funding was support women who were pregnant and were in the North Carolina women's jail. They provided prenatal services while they were in jail, but they also met them when they were walking out the door. Whatever time of day or night that was, they had a member of staff, a peer or social worker, meet them at the door and get them into the residential program at Horizons. They did that because they once lost one of their moms who had gone back into jail and walked out at midnight or whenever she got released, and no one was there to meet her except the ex-boyfriend who had gotten her involved in the drugs in the first place, and she died. So they have created this seamless process, and they have not lost anyone. And she started that work in 2020, so she's not lost a mom, and over 300 moms that have gone through that process and then stayed in Horizons. So again, it's we know it's possible when you can put all of the supports and all of the components together, the medical piece and also the social pieces. Don't Quit the Quit has multiple components at the University of North Dakota School of Nursing. But I will highlight, the one I'll highlight here is that they are training staff in WIC agencies to give them a basic understanding about addiction, about medications for opioid use disorders, so that they can have a little bit of knowledge, some ways of having a conversation if it comes up. They actually are required to screen for SUD, but they didn't have any particular way of doing that, any particular guidance on how to do that. And that piece of connecting, when moms go in for services, for WIC services, to know that it's also a safe place to talk about and to encourage them to stick with their own treatment has been incredibly successful, not only in North Dakota, but she's gotten a request and has done that training now in several other states, and is talking with the U.S. Department of Agriculture about doing it more widely. So again, a resource that is available to all of you. Renewal House was another program similar to yours, to Parisi House here, where we expanded their services during COVID. And then two of our recent community-based organizations, which again, I think would be great potential learning partners for Parisi House. But just to give you a sense that these programs do exist. There are not enough of them, but there are partners out there to work with. One is Maggie's Place, which is based in Phoenix, Arizona, and the other Meta House in Milwaukee, Wisconsin. So I'm just going to end with here, cover of our most recent annual report. Includes a mom in the corner with her two kids in Halloween costume who are from Maggie's Place, graduates of Maggie's Place. So what did we learn? These programs do exist. There are not enough of them, but they need to be comprehensive. We need to think about the medical, the other health needs. Nobody just has one diagnosis, mostly. And also the social and economic, and what's the trajectory from a point where a mom and child might come into a program to the point where they're ready to leave, perhaps 9 or 12 months later. Are they ready to do that in terms of a safe place to live, a job, a driver's license, as well as whatever they need next in terms of their health care and their babies? We need the care to be dyadic. Again, moms and kids together, parents and kids together, with services that think about the parenting and them together, as well as what they each might need. And longitudinal. These are not 30-day programs. The successful programs are really engaging for 6, 9, 12 months. And tailored, and this is where the peer staff, the peer support staff, people, moms, people who have gone through similar experiences are so critical to engaging with people as they come into a program, using a recovery framework. And one of the things I mean by that is an understanding that people do relapse. So having a way of managing relapses, which is not, well, you can't come here anymore because something happened to you, which is part of the process of recovering. And again, when we're learning that from our programs like Horizons and Team Lily, these are life-saving programs for the moms, for the individuals, and they're family-saving in terms of keeping kids and moms together. Challenges, there are not enough of these. Even in the proposals we get, I don't see enough of these, even looking for funding. The transitions, what happens when you get to the end of the 9 or 12 months, how do you help moms get to the next level? Making sure that on the front end, there's strong access and linkages to medications for opioid use disorder. Again, I was saying to David, at least we know there are really effective medications for opioid use disorder, and we should be using them much more than we are. And again, always making sure that the care is culturally and experience sensitive to the population you're serving. So I'm going to stop there. Right. Sorry, Isabel. Don't know how long that
was. So I go back to my initial comment on the introduction of Dr. Scott. I think the room could see how fortunate in these really troubled times, how fortunate we are to have such professionals trying to bring some light to pretty tough situation. So that said, we want to get really more deep, sort of do a deeper dive on talking about family-based treatment. And, I appreciate that as Dr. Scott was talking about some of the funded programs, it reminded me of many of the things that Parisi House is doing now, why it started back in 1994, what the need was then, and how over time, right now we are seeing the effects of local, the opioid epidemic, but now the intrusion, I think, of fentanyl into our local treatment system and into the wider community, and how it's impacting moms and kids. We are still, I think, as an area, still suffering from the baby Phoenix episode, and I know both as a region and as a community, losing infants to fentanyl exposure, use of the parents, dependency on the parents' side, are putting at risk our most vulnerable. And it's shining a light and making very specific our need locally, but also nationally, for more family-based treatment. When I was at the White House Drug Policy Office, I think SAMHSA counted about 90 sub-programs around the country. 90 some programs around the country.
And to say, and probably programs that have, what, about 20 beds? So, yeah.
So we can all do the math. And one of them that I actually went to was Mineta House in Milwaukee. And those pictures of the moms and kids, when I was speaking at Mineta House to the moms one night, one of the 2-year-olds grabbed my leg. And I'm talking and trying to give my prepared remarks that my DC staff work so hard to prepare and all, and say all these really profound things. And it's hard to do that when the 2-year-old's hanging onto your leg. And I don't know about you, but I don't know if you've ever had a professional moment where something became very clear to you. But it became very clear to me, having a 2-year-old hanging on my leg, talking to his mom and other moms, trying to find their recovery path, that these programs absolutely had to be protected. And going back to DC and dealing with OMB or dealing with HHS or whoever it was, that somebody had to actually put a circle around those programs and make sure that funding actually stayed in place. Because the funding that actually supported those 90 programs was like a rounding error for OMB. They could blink and actually it would just go away and no one would know. But that little kid and that mom knew. And the moms in Parisi and the other family-based treatment programs in this area know very, very well what it means to keep those families together. And to be in treatment and to see why you're working so hard every day, to find your recovery path. So again, one of the things that we've been seeing, Dr. Scott, locally is that, fentanyl is making a very drastic impact on our local treatment system. Our chief medical officer and others are finding that, issues around withdrawal management, and then how to, and then adding in Suboxone, adding in, and all the other treatment interventions is so key to keeping people, moms, in treatment. Mm-hmm. One of the other programs that actually Mineta House actually uses, that we use as well, is Celebrating Families. And it's a trauma-informed skill-building curriculum, again, focusing on children and family well-being. So, again, there's so much more that we can do to create these sort of non-judgmental, caring environments for moms and their kids, to keep them engaged and in treatment. So I guess one of the things that I want to make sure of as we have this discussion before we enter into the Q&A, really is to kind of get your sense as you travel around the country, I think, of, again, we're at the beginning, probably, stage of entering into this phase of this fourth wave of the opioid epidemic related to fentanyl. For family-based treatment, for policy reasons, I would just turn first to ask, so for policy, what are your suggestions? We're dealing with policy folks in the room. We're county staff here. What would be your suggestion on?
Okay, so a couple of things. So I think on the policy side, I would say the most concerning thing to hear, both as a physician and a public health person and now doing this work, the most concerning thing to hear is that a mom could be criminalized and her kid taken away because she's taking a medication that was prescribed by her doctor. And that obviously varies by state.
Okay,
so,
I just want to make sure that we're projecting in the room. Sorry, I think the fan just went on. So
okay, so so just saying that, so for in many states, and again, I apologize for not knowing what where you guys are, but in a context where there's a lot of backlash towards some of the policies around people with substance use disorder and access to treatment, I think it's really something for us all to be mindful of, that the risk of someone being criminalized or or the family separated because the person tests positive for buprenorphine or methadone, and she's in a treatment program because that's what her doctor prescribed for her to take, and that's a healthier option than risking going into withdrawal while you're pregnant, or a healthier option certainly than taking illicit drugs off the street, is, I think, a really devastating thing to think about. So I think making sure that we're not doing, that there were aspects of policy that we should be looking at, and making sure we're just not making it even more difficult for people to connect with treatment. Because why would you go into treatment if you knew that was going to be the risk of that outcome on the other side of it? I mentioned the change in the drug testing rules at the Massachusetts General Hospital. That's something that locally everyone could be looking at. Working between, in New York City, the public hospitals and the child welfare department and health departments work together to say, let's come up with a protocol around child welfare reporting that didn't report everyone. And partly it was because the hospitals were reporting everything, and the child welfare people were like, we could never get to this many cases. So does everyone have to be really reported? And the back from that is like, does everyone have to have a drug test in labor and delivery? Or it should be done where there's a clinical reason to do it. But asking those questions, and then maybe tailoring and fine-tuning those approaches could, I think, would take us a long way on the policy, and again, take away some of that fear. Because if we can't get women engaged in wanting to be in treatment, then we're not going to get to any of those improved survivals.
I just have to underscore kind of the profoundness of what Karen just said right now, and also what the learning, right? Just to underscore the learning that's happened by the foundation in these 5 short years.
Again, just to add one more thing on the when you talk about the starting to see fentanyl, and with all deference to the frontline clinicians, because I'm not doing that, but I do talk to a lot of them, and and there is there's a lot of good work out there and evidence. There's a lot of good research in terms of the safety protocol, the safety profile of buprenorphine and methadone during pregnancy. They're not, it's still a medication. I'm not saying it's not perfect. It's not as safe as not taking a medication, but it is a lot safer than, again, going into withdrawal or precipitated withdrawal or using illicit drugs. And there's some really good work. Again, Dr. Andre Jones at UNC has led a lot of that work, and it's published in New England journals, just about different ways of dosing medication in different stages of pregnancy to make sure it's having the maximum effect with the minimum potential impact on the fetus.
If there's anything that we can get out of today's session is, as a bullhorn for all of us, is we could get what Karen just said out into the community. For moms, for women to understand, for doctors, for frontline clinicians, is to understand that access to this medication and use of the medication is so critically important for the mom and the baby. Right? And I think a lot of folks are really worried and scared, not knowing that information, is that they'll have too many fears and stigmas, and then they won't even consider it.
Yeah.
And you think in 2024 we'd be a bit different, and we're not. So I just want to point out that you have the little green cards in front of you. If you have a question, please write them down. We're collecting them now, and we'd like to actually turn towards our Q&A now. And as we do, I also want to just, we've talked a bit about some of the programs in Parisi, but I just want to say thank you for one of the Parisi House graduates, Christy Williamson, who is here, joined us today, to be here today. Thank you, Christy. And I just want to thank you also and give shouts for 5 years in recovery last Friday.
Thank you. I want to say I am a direct result from the Parisi House program. I was there for 6 months, and you talk a lot about it needs to be a 6 to 9 to 12-month program, and about the Lilly program where it's continual over years. I believe that is the success for my recovery, because when I left House on the Hill, I was given another outpatient program. And through that outpatient program, I got pregnant again really quickly. So they kept me in the outpatient program. Well, actually, they kind of kicked me out because I stayed there for longer than I was supposed to. And that's where I was comfortable. And they drug tested me, and they gave me tools, and they just helped me, and without that extra set of program, I don't know what would have happened. I really felt like there needs to be that transition. Parisi House isn't where it needs to stop. It needs to continue on to another program. And because I continued on with that second program is why I'm here today with multiple years of recovery. And I have all my children with me, and my life is so good these days. The last thing I'll say is you mentioned about the kid holding onto your leg, and I can tell you that I go to Narcotics Anonymous meetings, and that was a big thing for me. It was I had 2 small kids running around, and it was loud. And I never really felt like I got the message, or everyone else was distracted by my kids. So I started my own Narcotics Anonymous meeting here in the Santa Clara Valley, or Santa Clara County. And it's called Clean Parenting. And all of us mothers with kids, we all get together, we have a meeting, it's loud, we talk over the kids, we let them play on the playground. And that's what I do for my recovery. And the last thing that I just want to mention is that I still go up to House on the Hill on Monday nights through H&I, and I bring the message of Narcotics Anonymous to the women, and that also helps me with my recovery. It's funny how when you help others, you also get the same thing in return. But all of that all together is why I've been able to maintain my sobriety and my clean time. And also, one last thing is House on the Hill offers an aftercare program, and I've been going that ever since I left. So aftercare is actually held in this room once a month, and we all get together, we have some food, and we talk about what's working and what's not working. The combination of all of these things that happen after the program is what I believe keeps me focused with my recovery. So thank you, Parisi House.
Thank you.
Thank you, Christy. That's awesome.
So great.
Yeah, congratulations. 5 years. That's yep. Thank you. Okay, perfect. Thank you, Isabel. All right, the first question is, Dr. Scott, what are the best ways to increase access to buprenorphine and other substance use medications?
So I would say a couple of components to that. One is to broaden the healthcare workforce that is trained and feels comfortable prescribing and managing medications for opioid use disorder. What we've seen has been helpful is programs where for example, in North Carolina, where we basically had a set of experts in the hub at UNC who did some initial training with clinical staff, primary care staff at health centers. But that's not the thing that gets you started to prescribing. What really helps you is knowing that once you start, you've got someone who's sort of a mentor or a coach that you can call. So the people we funded, the clinicians we funded to do that training, also made themselves available. Basically, that a primary care doc in a rural county could text or call the psychiatrist or the primary care specialist at UNC and say, I've just started this person. Is it 8 milligrams or 12? What do I do next? Or how much do I put them on? Just these really, the things you might not think about. So you have a patient in front of you. How do I talk to this person? And so that kind of training with that mentoring, we see is really critical. And while you kind of feel like you hope to get to some point where you don't have to keep saying that and doing those programs, I don't think we're there yet. I think we still need that kind of support and training out there. Massachusetts has a program where they have a hotline where you can call for, a clinician can call for some guidance from a specialist. Is another example of that across a number of mental health SUD issues. But the other thing we see is really important is the peer part of the workforce. So in terms of getting the patient, so that part was like getting the clinician ready, to prescribe and treat. But the other piece is getting a patient, kind of to a point where, at a point where they're open to talking about medications or talking about any aspect of treatment, however they want their treatment to look. And from the projects we're funding, that's where we see the peer recovery coach workforce can be so important and so critical in terms of just starting the conversation. And again, very much the starting, meeting the person where they are, talking about potentially their recovery path, which might be the same, might be different, but encouraging them to, in a safe way, start to engage in the system. So I look now for programs, again, where we can do more on the training clinicians and be broad. When I say train clinicians, really think broadly about how we use the workforce as best we can, given all of the shortages in the workforce. So it's people with MDs, with medical degrees, nurse practitioners, PAs, who are actually doing more of the uptake of treatment in this area. It's thinking about how we maximize the use of other nursing staff as well, and social workers, etc.
This is more comment, but I just wanted to thank you for the inclusive and accurate language you use, like pregnant people and opioid crisis. Language really does matter when engaging folks.
Thank you.
And I just want to thank you so much.
Thank you. Thank you.
Will Team Lily move into other hospitals in in surrounding counties? We know these are for pregnant moms, and the second question, how do fathers get incorporated?
Yeah, that's both great questions. We now have a project in, so I mentioned Renewal House. I'm going to take questions backwards. So Renewal House in Nashville, which is a program similar to Parisi House. And then we got a proposal from another small organization in Nashville called My Father's Place. And this was someone who was in recovery, and he said, I look around, there are always places, his wife also, unfortunately, was in a recovery or active substance use. He's like, there were places for moms and kids. There was no place that I could go as a dad who was trying to be in treatment and recovery with my kids and it wasn't unfortunately safe to leave them with their mother, and how he struggled. So he started this program in partnership with Meharry Medical College, which is providing the treatment for these dads, and they're all, always at capacity, always, because there are really very few that think about that. Absolutely. I mean, I think every program should, where there's a dad, a partner, another parent, and it's safe to do so, should be incorporating them into the programs. Having said that, what was the first part of the question?
And then the first part was, will Team Lily move into other?
Oh, yeah. So part of what of our funding to Team Lily is to help the PI do some economic analysis, and we're hoping to add a little bit of Medicaid analysis to that. These are occasionally, reminders to my board of what I want to do. So, oh gosh,
That's all right. That's all right.
Sorry.
Yeah.
Sorry. That might not be a good sign for my project, right? But we are trying to, but it is for the team there to be able to make a strong case to the city and to the state, California Medi-Cal, on the benefits of helping to support these programs. I know that she had already gotten some interest from one or two other hospitals in California, as well as a couple of public hospitals in other parts of the country, like Grady Hospital in Atlanta. So definitely there is hope, and that's one of the things we're trying to work with her on.
That's great. That's great. This question is really about a sort of broader issue, but if you could share your perspectives around the recent changes made to 42 CFR. So we applauded the opportunity to coordinate care across the health system, but we're also scared of the info being used against people in the criminal justice system.
Yeah. Well, we need Wes for that one.
I know,
right?
we need Wes. Like, where is Dr. Clark?
The MD-JD one for that one. Yeah. I mean, only that, having been on the front end in hospitals of implementing HIPAA, I think as someone who hasn't spent, sort of decades like our colleague in, particularly on this issue, I do look for the piece that's around, where the patient consent lies. And I think what I would hope to find, and regardless of where we are on the rule, is that there's a clear focus on communicating to the patient on what what the information is, how they want it to be used. I think there's definitely, you can see the benefit in terms of coordinating care and being able to have a whole picture of the person. But there should always be a fundamental, asking the patient how they want which piece of their record they want shared. We definitely do see on some of our projects, it comes up against a wall when they're trying to coordinate care. So the ability to have flexibility there, I think, is good. But again, it should always be in the whole context of what's going to be best for the patient, which isn't, my little medical perspective. It's, their whole social picture.
Dr. Scott references one of the founding board members on FORE, Dr. Wesley Clark. For years was the Center for Substance Abuse Treatment, CSAT, director. And Wes really is one of and Andrew, Dr. Barthwell, are the reasons that actually I'm on the board of FORE, former federal colleagues. Wes is an MD, JD. And one of his concerns was always around how the information would be utilized. And it would be utilized against folks with substance use disorders. And so I feel like, on the question, I just feel a need to get out Wes's worry.
Yeah. I mean, and even more so, and if there's time for like a little side anecdote, but I was, but I stopped at an urgent care yesterday, and to my surprise, when I went in to see the nurse, she started asking me about, sort of looking at medications that had been prescribed to me. And I was like, I didn't know that she had access to my Cornell medical faculty records in New York. And she's like, oh, it's all Epic. So it was fine. I'm like, no, I'm not, it's, but it was a moment of like, wow, there was no, okay, if we look at your whole record, or there was absolutely nothing about, why I was there that required them knowing my whole medical history. And yet it was incredibly seamless and easy. And I was just really struck by that. She's like, as long as it's an Epic, we could find it.
Wow.
Which is a little scary if you're thinking about, if you're talking about this.
Right.
Right.
Especially, I think, especially as on a policy basis, as we look to recriminalize actually use.
Yeah.
Right.
Yeah.
And, having been part of an office in an effort to turn around the federal government's response and say that, look, we tried to arrest our way out of this. It absolutely didn't work, and we need to do this.
Yeah.
It feels to me that, unfortunately, with the different waves of the opioid epidemic, that there is a knee-jerk reaction back to looking at arresting our way out of this again. Yeah. And I think it's born out of frustration and, with not having enough solutions and seeing enough, turnaround in the data and all the really tough numbers. And so, let me bring this all back around, is I appreciate you and FORE and the staff's efforts to accelerate solutions in the community. However big or small those lessons are.
Thanks. Yeah, we're definitely worried about the same things, certainly. And we are, in fact, in response to some of the very recent policy initiatives or changes, it was one of the reasons that Team Lily, for example, is something that we really want to lift up, and the UNC Horizons program, that these are programs that, if you have all these things in place, you can really have an impact, right? But you can't expect that you can do it in 30 days. You can't expect you can do it by just picking 20% of the program. These need to be comprehensive. These are complex. These are, potentially things that have developed over long periods of time, right, and have multiple components to them. So we're going to be putting out around Mother's Day. We'll put out a big piece about Team Lily and the and the moms that have been in the families in that program and the success there. But just trying to continue to try to get those stories out, and there are ways to do it, but they need to be funded properly, need to be expanded, and you need to think about them in this comprehensive way. And I really like what really helpful to hear your experience on what comes next on that piece. If we're going to have an impact, it's just it's not something where we're going to, as you said, there are no silver bullets. I think we would have found them, right?
Right. I mean, and again, I appreciate that it can be frustrating for the general population, the public, but on this issue, I just don't know any family that somehow is not affected on this issue. I mean, it's ubiquitous now, and I just feel like our best information, our best knowledge has to be front and center. And again, I just am so grateful that Dr. Scott took some time out of her week to stay to have this conversation with us, and to impart the knowledge. And we'll get these slides out if you're interested in these slides. Sure. We'd love to be able to share them. Yeah. That's great. And so at this point, again, I want to thank you all for coming out today, taking time out of your busy week. And we're going to have some time, hopefully now, just informally, to talk amongst ourselves. And if you have other questions for Dr. Scott. Lastly, I just want to thank the staff for putting this on. This came up kind of quickly because of an idea born out of, hey, Karen, would you mind staying for a little while? Could you do that? And then next thing you know, and then I brought it to the staff. So it was, and then, so I want to thank Pat, Kevin, Isabel, Cassia, Karen, Elizabeth, and Baronial and Alan for taking pictures, and all for putting this on, because once Karen said yes, then I was happy enough to turn it over to all of them to make happen. And they did.
And they did.
And we're going to get the recording out so that other folks can hear and learn and sharing the information. So, so thank you to the staff. A huge thank you to Dr. Scott.
Oh, thank you,
here.
Thank you.
Thank you. Please come have refreshments. Come meet Dr. Scott, and thank you all.